Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to yet another edition of very educational lectures for you. The speaker for the first session of today is our honored guest from the USA, Professor Thanh and Nguyen. Professor Thanh and Nguyen is the Director of Interventional Neurology, Neuroradiology at the Boston Medical Center and Professor of Neurology, Neurosurgery, and Radiology at the Boston University School of Medicine. She is the president-elect of the Society of Vascular and Intervention Neurology, the first woman in its 15 years. Congratulations. Her clinical interests are focused mainly upon intervention neuroradiology. She has been involved in a total of 3,000 INR procedures, including more than 500 interventions for aneurysms in the form of coilings and flow diversion and 400 acute stroke interventions. Her other clinical interests include neurocritical care, preoperative embolization for head and neck tumors, carotid and intracranial stenting, subdural hematoma embolization, vertebroplasty, and kyphoplasty for acute spinal fractures. Dr. Nguyen has authored more than 150 peer-reviewed publications, contributed to national guideline statements and book chapters. She is a reviewer for neuroendovascular section of 8 neuroscience journals and had more than 80 presentations at scientific meetings on a national and international level. She serves on section editor of Stroke, editorial board of Journal of Stroke and Cerebrovascular Diseases, Journal of Neuroradiology, and associate editor of Frontiers of Intervention Neurology Journal. We are extremely thankful to her for accepting our invitation to be a speaker at our webinars, and today she'll be talking about image selection for endovascular thrombectomy in the late window. The speaker for the second session of today is our honored guest from Pakistan, Professor Syed Athar Enam. Professor Enam is a professor of neurosurgery and chairperson of Department of Surgery at the Aga Khan University Hospital, Karachi, Pakistan. He joined the AKU as an associate professor in neurosurgery in 2003 and developed a state-of-the-art neurosurgery program that has trained a new generation of surgeons for Pakistan. Dr. Enam has published acclaimed research on brain tumors and is an expert in minimally invasive spine surgery. He has been a recipient of several awards and honors, including the Excellence Award in Neurosurgery by the Pakistan Society of Neurosurgery, as well as the prestigious Sitara Imtiaz Award, the third highest civilian award by the government of Pakistan. He is a life member of the Sigma C, a scientific research honor society, as well as the founding president of the Pakistan Society of Basic and Applied Neurosciences. We are extremely thankful to him for accepting our invitation to be speaker at our webinars, and today he'll be talking about benefits of awake craniotomy in resource limited settings. The chair for this first session of today is our distinguished faculty from Japan, Professor Shigeru Miyachi. Professor Miyachi is the professor and director of Department of Neurosurgery and Neuroendovascular Therapy Center, Aichi Medical University, Aichi, Japan. He is the president of the Asia Australasian Federation of Intervention Therapeutic Neuroradiology. He was the past president of the AFTIN Congress in 2012 and vice president in 2014-15. He is a noted author with several publications in various peer-reviewed journals. He has received several awards, including the Best Doctor of Japan Award in the past. We are extremely thankful to him for accepting our invitation to chair the session of Professor Thanh. The chair for the second session of today is our honored guest and senior faculty from India, Professor Dilip Panikkar. Professor Panikkar is one of the most famous faces of neurosurgery in India, who currently serves as a professor and head of Department of Neurosurgery at the Aster Med City Hospital, Kochi, India. He had a long, outstanding career earlier, having served in prestigious institutions like Sri Chitra Hospital, Trivandrum, as well as Amrita Institute of Medical Sciences, Kochi. He is an important member of the Neurosurgical Society of India, as well as Skull-Based Surgery Society and Stereotactic and Functional Neurosurgery Society of India. An exceptionally talented neurosurgeon with more than 31 years of experience to his credit. His areas of special interest include neuro-oncology, endoscopic skull-based surgery, reconstructive surgery for craniofacial deformities, functional neurosurgery, and neurovascular surgery. He is an invited faculty to various workshops and conferences around the world. He is also a noted author with several publications in various peer-reviewed journals. We are extremely thankful to him for accepting our invitation for chairing the session of Professor Syed Athar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely thankful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Seng from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Shigeru Miyachi.
So as Raja introduced, Professor Tan is a very famous professor about the mechanical thrombectomy and the imaging. And her today's title is Image Selection for Endovascular Thrombectomy in the Late Window. Yeah, this is a very hot topic because mechanical thrombectomy is very important maneuver and very important so method for the emergency stroke. And also, this is not only the neuroradiological field, but neurosurgeons. And it is so very important and very important for all the neurosurgeons, because particularly in Asian countries, the neurosurgeon has a big contribution for the emergency stroke. And the mechanical thrombectomy is, for example, in Japan, the mechanical thrombectomy is one of the important maneuver to learn for all the neurosurgeons. So this topic is very hot, and because now the mechanical thrombectomy is a very good result, and maybe the more than 90% will be successfully recanalized. So, but so remaining issue, for example, very low aspects patients or very high aspect ratio, aspects patients, or the medium vessel occlusion, and also as a result of a dawn or diffuse 3, such a late time window, we have a very difficult to select or to triage the patients. I think the Professor Tan will have this very good key or very good points to learn and to have a good selection for the patients in the right time window. And as you know, she has a very excellent issue papers in German Neurology for the same contents. So I think I look forward to listening to your direct lecture. Okay, Professor Tan, are you ready?
Yes. Professor Minachi and Professor Krishnan Kuti, thank you so much for the invitation and the very kind introduction. It's a great honor to be among colleagues from Asia CNS, and I'm happy to share my slides. So the topic today is looking at imaging selection for patients in the late window. These are my disclosures. Most pertinent is I have received research support from Medtronic and SVIN for this project. As introduction, as you know, DAWN and Diffuse 3 trials really revolutionized how we treat stroke patients in the late window, being 6 to 24 hours from symptom onset. And the important things to notice from these trials was that advanced imaging with CT perfusion or MRI were the mainstay of selection for patients to get into these trials. However, the issue is that advanced imaging is not widely available. Dr. Greg Albers, who was the principal investigator for the Diffuse 3 trial, wrote a very nice editorial in Stroke soon after its publication, indicating larger benefits of treatment with later treatment. And he called this the late window paradox, whereby if you compare it to the early window, patients who were treated in the later window seem to have a wider treatment effect, as you can see from these wider margins between endovascular therapy versus the control arm in the late window compared to these narrower windows in the early window with the Hermes analysis. And the explanation for this was that because they used advanced imaging, they were so good at selecting patients that this is probably why we had this wider treatment effect. Whereas in the early window, you were permitted to use CAT scan as your triage of choice. And so Dr. Albers had a nice commentary saying, because access to acute MRI is limited, unless you're in Japan, of course, CT perfusion would be required to select late window stroke patients for thrombectomy at most hospitals. And these trial methodologies and the guidelines trickled into the AHA guideline, whereby they're saying that it is recommended to use CT perfusion or diffusion-weighted MRI to triage patients for LVO in the 6 to 24 hour window. It's a level 1 indication, and that's natural because that was the method by which patients were selected into these trials. So naturally, the guidelines follow the methodology of the trial. And so in the ESO, the European Stroke Organization, along with ESMINT, they also mentioned that it is necessary to do advanced imaging in the late window with a strong recommendation. And in Canada, again, beyond 6 hours, one would require additional advanced imaging to triage patients to be treated in the late window. The issue with the advanced imaging recommendation is that it is not widely available. My colleague, Dr. Sunil Sheth, and colleagues in Texas did the study of patients with acute stroke presenting to hospitals in Texas in a Medicare data set. And basically they found that most patients presenting to these hospitals with stroke were presenting to hospitals that did not have CT perfusion. 69% were going to hospitals that did not have CT perfusion. And if you think of Texas as a microcosm, meaning a paradigm for the United States, and being a well-resourced microcosm, you can think about the disparity in availability of advanced imaging in other states. And this study was as of recently 2017. And then we take this to Africa, where recently this nice paper by Dr. Rushdie and Dr. Shokri looked at the availability of treatment modalities and imaging in Africa, and you can see this disparity widens. So if we think about the goal of imaging, it is really to identify patients who can benefit from treatment. A less appropriate goal of imaging is to triage patients that may have better outcomes than others. And this is in the context of an individual patient. Jean Raymond is my mentor from Montreal. He had this nice quote saying that better clinical outcomes can be observed among patients selected on optimal CT perfusion or MRI parameters, but this selection can improve your overall statistics at the potential cost of denying care to many patients who could benefit. So the objective of our study, which was the CT for late endovascular reperfusion study, was to evaluate the clinical outcomes of patients with proximal anterior circulation large vessel occlusion in the 6 to 24-hour window selected by non-contrast CT and CTA, of course, to look at the vessel occlusion versus CT perfusion or MRI. And the primary endpoint was 90-day MRS distribution, and the secondary outcomes are as listed. Our pre-specified hypothesis was that there would probably be no significant difference in outcome if you selected patients based on non-contrast CT compared to if you selected based on advanced imaging. This was a multinational cohort study of consecutive patients between 2014 to 2020. ICAT, M1 and M2 occlusions were included in the study. So very similar to the Dawn and Diffuse 3 guidelines, other than we included patients with M2 occlusions and also patients with baseline MRS of 2, which was not included in Dawn or Diffuse 3. This is a flow chart to show how we arrived to our final cohort of about 1,500 patients in a complete case analysis for the study. And so overall, we had about 500 patients selected by non-con CT, 750 by CTP, and 300 by MRI. And for vessel imaging, CTA was by far used in the majority of patients in 98%. For those who used MRI, we saw MRI as the modality for LVO selection in about 270 patients. And these were patients mainly in France and Germany. For baseline characteristics, I draw to your attention the baseline NI stroke scale coming into the study was quite high, 17, just like in the early window. And if you look at the status of patients in terms of transfers, we saw more patients selected by CT if they were transferred, and also by MRI as well. And more patients in the IV-TPA treatment group underwent MRI compared to the other modalities, which is natural thinking about the Wake Up and Extend trials where they selected patients based on MRI. In terms of baseline aspects, it's important to note that most patients in the study had very good looking aspects, whether they were selected by CT, CTP, or MRI. The median aspect score, or the Alberta Stroke Program early CT score, an indicator of how much infarct you have on your baseline CAT scan, was 8, and the interquartile range was about 7 to 9. So 75% of our patients had baseline aspects between 7 to 9. And what we found was that essentially there was no difference whether you were selected by CT versus CTP versus MRI by 90-day ordinal MRS shift. The secondary outcomes were to look at functional independence. And again, it was largely similar. And we had higher reperfusion for TICI scores in the patients who were selected by non-contrast CT and CTP compared to MRI. Safety outcomes are important to report because obviously we worry more about hemorrhage in the later windows. And so numerically, it was higher in terms of the symptomatic hemorrhage in the non-contrast CT group compared to the advanced imaging group, but it was not statistically significant. And mortality also numerically higher among the CT selected group, but again, not statistically significant. We also looked at time metrics, meaning how much time did it take for patients to get imaged to puncture, whether you were selected by non-con CT versus advanced imaging. And the interesting observation, as you would surmise, is that patients who were selected by non-contrast CT had shorter door to puncture times compared to those who were selected by advanced imaging, and by about 20 minutes. So if we look back at the AHA guidelines, even in the late window, 6 to 24 hours, they still recommend that evaluation and treatment should proceed as rapidly as possible. So even if you have that later window and you think, oh, I have more time because maybe the patient has more collaterals, you still want to treat your patient as rapidly as possible. So non-contrast CT could be one way of achieving this metric. And then we also looked at outcomes for those who arrived directly to the mothership patients, meaning directly to the endovascular centers, endovascular performing centers. And we found there was no difference in outcomes for mothership patients, whether selected by CT versus advanced imaging. And in our cohort, of those who were reperfused, they did better than those who did not reperfuse. And it didn't matter whether you were selected by CT, CTP, or MRI. You did better if you reperfused compared to if you didn't reperfuse. This is a study from my colleagues at Mass General, and they mentioned that in this cohort from the Get With the Guidelines database, that EVT was performed frequently after 6 hours, but the outcomes at discharge were worse compared to those who were treated within 6 hours. And they recommended that further efforts are needed for optimal EVT outcomes in clinical practice settings. My commentary on this study is that while maybe your outcomes are worse compared to the first 6 hours for those who were treated later, really the comparison you want to see is those who were not treated. So what is the treatment effect for those who were treated versus those who were not treated in the late window, and not really compare it to the early window. So the limitations of our study were the retrospective design could have led to selection bias, limiting the generalization of our results. We had differences in imaging interpretation, selection paradigms, and the automatic CTP software across multiple centers could also introduce bias. CTA collateral score was not measured in our study, and most sites did report that collaterals were not routinely used, and obviously that could affect the patient selection. And also, we don't know about the patients who were excluded by the triage process. To further confirm or validate our study, we look at the Aurora analysis. It's a systematic review of patients treated beyond 6 hours. And this is the equivalent of the Hermes analysis for the early window, 0 to 6 hours. And basically, those who were selected with by aspect score still did very well and had a higher chances of good outcome compared to their control group. And so why is this? Dr. Noguera had a nice quote at the recent SVIN meeting. We were discussing this, and he mentioned that CT scan is like, in the late windows, like a red wine. It gets better with time. You can see the infarct better as time goes by. And if you don't believe me, then if you think about, or if you're skeptical, I'd love to draw your attention to the most successful recent Japan rescue study. Congratulations to Dr. Yoshimura, Dr. Sakai, Dr. Yamagami, if you're in the audience, on this amazing study where they looked at patients with large core infarct, showing that even if you erred, even if you miscalculated what your aspect score based on your non-contrast CT, patients, if they had a large core presenting to you, still had a better outcome with endovascular therapy compared to medical group. And the treatment effect was 31% for endovascular good outcome compared to medical management, 12.7%. So odds ratio of 2.4 times doing better with endovascular therapy compared to medical. And recall that our patients, most aspects were really good. They were about 8. And so if there is a treatment effect in the late window, and this study also carried out to the 24-hour window, granted, most being selected by MRI, you probably have some latitude to consider your patient for treatment, even if you erred on a wrong aspect score. And congratulations to our Japanese colleagues who were the trial leaders and recruiters for this study. So in conclusion, in patients with stroke due to ICA terminus M1, M2 occlusion, presenting 6 to 24 hours from onset, favorable outcomes selected by CT are equivalent compared to selection by advanced imaging with CTP or MRI. There's no increased risk of hemorrhage or mortality by imaging modality. Door to puncture times are shorter in patients selected by non-contrast CT compared to CTP or MRI. So these findings have the potential to widen the indication for treating patients in the extended window using a simpler, less costly non-contrast CT as an alternative to CTP or MRI. Where do we go from here? There are ongoing studies, Mr. Clean late and resilient late, that are taking patients in the late window with CT selection only compared to medical management. And if these trials are positive, it would give us level 1 evidence to state that patients can be selected by only a non-con CT compared to advanced imaging. And Walid Brzezinski, interventional neuroradiologist at Mayo Clinic, wrote potentially in this tweet that CT perfusion could go in memoriam. Dr. Tekli, who's an Ethiopian interventional neurologist, when this paper came out, said, great news to developing countries. Having this study to validate the use of non-con CT in the late window could help in areas where advanced imaging is not available. And Dr. Kasravani from Toronto said that having this option could help the field reconsider and pull back from the reliance on advanced imaging for making endovascular therapy more accessible and care more equitable for patients who are impacted by large vessel occlusion stroke. I had the pleasure to meet a colleague from Honduras when I was at the SVIN meeting, and he said this study can give new hope for patients in the late onset for developing countries like Honduras, where essentially I learned that there are practices where after hours, if advanced imaging is not available, you are not eligible for treatment, so you cannot even get treated. And I didn't realize this until I had the chance to interact with several colleagues from around the world. So this was our publication. It takes a village to produce this project. So I thank all our collaborators for their contributions and thank the Asian CNS very much for this great opportunity to speak with you and share some of our thoughts on late window imaging for thrombectomy.
So very excellent lecture. Thank you, Professor Tan.
Oh, thank you, Professor.
Yeah, so very excellent. And but I have some questions. And I agree. You were so CT, plain CT, non-contrast CT is a very effective tool for the selection of the patients for mechanical thrombectomy. But what is a so very so big so advantage that for saving the time or for saving costs or both?
All of the above. All of the above. I mean, we showed that it's maybe 20 minutes faster to bypass the advanced imaging. The interpretation of CTP can take time before you make the decision. So if you can do less with more, more with less, then why not just go with a simpler imaging study? I know in Japan, MRI is widely prevalent and you have very easy access, but it still takes time. And you still have to screen the patient for, you know, pacemaker and metal. So you can skip all that part. Why not?
Yeah. So yeah, this is a very hot discussion all time. And but many hospital for the primary stroke center hasn't always have an MRI. So we have no idea to skip the MRI. So I think yeah, and also in the late time window, the plain CT will indicate the ischemic area already. So if there's, for example, 10 hours or so 12 hours after the onset, if the plain CT have a so larger area of the ischemic area, we don't do mechanical thrombectomy. But if such a so very late so time, the CT scan looks normal, we go to the mechanical thrombectomy. This is very positively. Yes, I think so. In this meeting, CT non-contrast CT is so very useful, and I think this is only the CT non-contrast CT we can do. We can so decide the mechanical thrombectomy.
Exactly, because if you see the infarct, of course, you're not going to offer if it's completed infarct. And if you don't see the infarct and you say, oh, brain looks good, and you're 12 hours out, then it would be a great patient to take to the lab. And often some of these patients, they go to CAT scan and sometimes they go back to the ER. So you don't lose time going back to the CAT scan to get the CT perfusion or to go to the next MRI, because that will easily cost you an extra half hour if you didn't get it at the same time.
Yeah. And also in the Japanese survey, I see all 80%, 70 or 80% of the patients treated with mechanical thrombectomy is not strictly based on the criteria of the reported criteria. For example, the element study or the RCT design or AHA recommendation. 80% is out of the criteria. So in this meaning, the MRI has no useful tool. All the patients will so very positively go to the angiography room. So I think a plain CT is possible to select it.
And there's places that are going even more radical. So the Barcelona group, Mark Rebo and Raul Noguera, they're doing the WeTrust study where they're skipping CT altogether and they go straight to the cath lab and they do the Dyna CT or the Expert CT on the angio suite, and then they just make a decision right there. So there are extremes in that end too.
Yeah, this is another way. So the direct angiography, it's a good idea.
Well, we can invite questions from the audiences. Can put their questions in the Q&A box. In the meantime, if there are any questions from the panelists are welcome. You can switch on your mics, panelists, and interact with Professor Nguyen. My co-host Liu Boon Seng, any questions from you?
Yeah, thanks, Raja. Thanks, Professor, for a very nice presentation. I have two questions, Professor. Regarding using non-contrast CT to decide on mechanical thrombectomy, may I know how many percentage of patients that while plan for mechanical thrombectomy and found to be a negative for large vessel occlusion? And what's the reason for that? My second question, Professor, despite a shorter turnover time for a non-contrast CT patient who underwent mechanical thrombectomy, what do you think the opinion, why in terms of outcome, it doesn't make differ compared to those with a CT perfusion and MR? Thank you, Professor.
Sure. So the first question being what percentage of patients don't have a large vessel occlusion in the late window? I think the estimate number, if that's a correct question to answer, the estimate number for large vessel occlusion is 10 to 20%. There's a big range depending on selection, whether you're at the comprehensives versus the primary stroke center. So that range is wide. And then for the next question, why is there no difference? I think it's because it doesn't matter. The outcomes, the vessels, the brain, they're agnostic to how you're selected. If you have brain to salvage and the CAT scan looks just as good as in the early window, then you have potential for benefit, even if you're treated whether by plain CT or advanced imaging. So it's all about, you know, what you think is the clinical imaging mismatch, and you can use that as a surrogate with regular non-con CT, and you don't need to see that penumbra on that advanced imaging to make that decision. Your patient looks bad, NIH of 17, you know there's a big deficit, and you know there's a large vessel occlusion, so that's a great patient to chase.
Thank you, Professor.
Thank you very much. Any comments from Professor Panikkar?
No.
Thank you. Professor Takashi Kon has joined here. Any comments from you?
Yeah, thank you. And the next presentation, I'm Dr. Kon from Tokyo, Japan. I own the PSC. So because we estimate, evaluate the patients using by MR image, MRA, using MRI large vessel occlusion, and diffusion flare mismatch for indications. So it will take time. So however it's time. So sometimes I'm very suffering. Time to puncture is very important. I understand time to puncture important. And how they evaluate before thrombectomy? Which is important. How to evaluate important pre-thrombectomy? Much more. So NCCT will be enough, or sometimes we evaluate enough the diffusion and flare. So it will consume time. So I understand, but we estimate before thrombectomy. So if the NCCT non-quant CT scan is enough for evaluation, so earlier it would be better, I understand.
Yeah, great question. Obviously, diffusion and flare mismatch is extremely sensitive, and you were able to show that from Rescue Japan, this very successful large core study, that by just diffusion flare mismatch, you were very successful in selecting patients with large core and even show a benefit. So that's an extremely valuable technique. But if it takes time, and if you have a non-con CT, easy to go in and out of the CAT scan, 10 minutes, then that, based on our study results, if you have a good looking aspect score, being aspects of 7 to 9 was the most for the IQR interquartile range in our study, then I think you have enough evidence to, not enough evidence, but enough alternatives to say, okay, I can just take this patient to angio if there's a large vessel occlusion. I don't need to get additional MRI to prove that there's a huge infarct or a huge flare infarct.
Thank you. And there's enough to surrogate and CT scan.
So.
Okay.
Yes, it's
Thank
not
you.
going to make level 1 guidelines because it's not a randomized study, but it could be level 2 recommendation if the guidelines are revised.
Okay, thank you.
Thank you very much, Professor Takashi-kon. There is one question which has popped up on the chat box. In the decision making using NCCT, is it still important to do CTA or MCTA prior to bringing patients to cath lab?
That's a great question. So we do recommend CTA because most of the trials used CTA for selection. But if you have a hyperdense vessel sign and you have a patient with, the gaze deviation and contralateral hemiplegia, this is a patient screaming, I have a large vessel occlusion. So in some paradigms, you could just use that alone. But the problem is if you don't see that hyperdense vessel sign, then there's an uncertainty that there is a clot. So that patient could have a seizure, for example. And so you want to make sure you're selecting the right patient. And if you're going to wake up the neurosurgeon at 2 a.m. in the morning, you want to make sure there's an occlusion that he or she will chase after. So CT-CTA should still be the mainstay, because if you miss it, then you lose more time to go back to lab to see if there's an M2 or an M3 occlusion that might alter your treatment decisions for that patient. So we do recommend CT-CTA, but if you are with the patient, you see the hyperdense artery, or if you're thinking I want to go straight to the lab, you can go straight to the lab based on your clinical imaging mismatch and bypass the CTA. But overall, if I had to recommend for a stroke center, continue to use the CT-CTA.
Thank you very much. If I would like to inquire Professor Nguyen about have you explored the whole database and found the association of another innocent bystander in the form of an aneurysm or AVM in your study?
So we weren't looking at that specifically, but certainly when you're doing a lot of CTAs for these stroke patients, we find a lot of aneurysms, AVMs less commonly, as aneurysms are probably present in about 2% of the population. You'll see probably 2% of these CTAs demonstrating an aneurysm.
Thank you very much. Recently, I saw a paper in one of the journals which evaluated stroke and found quite a number of higher number of aneurysms. Well, thank you very much. It was a great lecture and we all really enjoyed it. I would like to hand over the podium to Professor Miyachi to hear his final remarks. Professor Miyachi.
Yeah, thank you very much. It's a very nice discussion. And I think in the only the non-conscious CT is a very useful tool for the late time window. And I think, as you said, the very early patients with such a mismatch imaging will be so essential. I think so. Yeah, but it's a very nice lecture. Thank you very much.
Thank you, Professor Miyachi.
Thank you very much. I would like to inform our viewers that as of now, we have around 985 people who are live watching this webinar on WeChat, YouTube, and Zoom. And we're extremely thankful to Professor Shubin for broadcasting this on the WeChat channel. I would hand over this podium to Professor Dilip Panikar, who is a chair for the second session. Professor, all the best.
Thank you, Dr. Raja. And I must commend Professor Nguyen for the excellent talk and for the lovely discussion that followed. I think that's very, very interesting. And this is always going to be a subject that's going to generate a lot of interest and discussion. The second